Welcome everyone, thanks for coming. I'm not entirely sure what this is called, it's a community forum. And I am Josh Knappenberger, I'm one of the neurologists here in Bozeman. With another hat, I am the medical director of the stroke program. And we have Heather Wicks. Heather is the stroke program coordinator. She's an RN, BSN, and she has a CEN. That is
Certified Emergency Nurse.
There you go. And so we're going to be talking today about some general information about stroke. We're then going to be talking in particular what Bozeman Deaconess has been doing with stroke. And then we're going to talk about sort of the future of stroke care. So here, let's get going here. First, a little quiz. Okay. So who's that guy?
Oh, Roosevelt.
Okay. And we've got.
Churchill.
Okay. And we have.
Stalin.
Okay. And the question is, what do these people all have in common? They'll share something in common.
Aneurysms.
High blood pressure and stroke.
Strokes.
We've also got Al Capone, Johann Sebastian Bach, Miles Davis, and two of the Three Stooges. They all died of stroke. Who else? Margaret Thatcher, Catherine the Great, Zora Neale Hurston, even Minnie Pearl. All these people died of stroke. It's a ubiquitous disease process that cuts across gender and race, and it is, well, what is it? Let's talk about it. What is a stroke? So today what we're going to talk about is what is a stroke? There's actually a lot of misconceptions about what a stroke is, and we'll talk about some of that. How do you prevent stroke? Something that a lot of people I think will be interested in. How do you treat strokes? That used to be sort of an oxymoron. It's not anymore. What is Bozeman Health doing about strokes, which is a lot of what Heather will be talking about. The answer is quite a bit and more every day. And what is the future of stroke treatment? So let's roll. Some basic dry facts, but they're pretty daunting. Almost 800,000 strokes per year, or about one every 40 seconds. It is, and there's a typo in this, and I apologize. It is the now fifth leading cause of death. It used to be fourth, but now it's the fifth leading cause of death in the country. It's going down because of better management of the effects of stroke. Unfortunately, it is the leading cause of serious disability in this country. You can see here that it's about a rule of thirds. With a stroke, about a third die, a third recover, and a third are permanently disabled. So, rightly so, it's one of the most feared disease processes. Over 4 million stroke survivors right now in the United States. That number is only going to be going up. Right now, the cost is a relatively reasonable $38.6 billion annually. That was in 2009. That's going to be up by 2030 over $100 billion a year just for direct and indirect costs of stroke. And it not only crosses all ethnic, racial, and socioeconomic groups, it actually targets more people of lower socioeconomic status and ethnic minorities, in particular African Americans, and actually more women than men have strokes now because women live longer. So when you ask women, what are you going to die of? Often they overestimate their risk of dying of something like breast or ovarian cancer. Big killers, heart attack, and stroke. What is a stroke? Well, the idea of a stroke is that it's a stroke from the blue. It's something that comes from just from outside, and it strikes you quickly. That's where the idea of stroke comes from. They've been known since antiquity. The old term in the English literature is apoplexy, which apparently derives its root something to do with a lightning storm. Again, this idea of something zapping you. And it's surprisingly hard to define exactly what a stroke is, and I'll talk about that a little bit. But for our purposes, think of it as an abrupt onset of neurological symptoms related to problems or alterations of blood flow to specific regions of the brain. There's a lot packed into that sentence, but I'll unpack it a little later. But the idea is it's abrupt. It involves specific parts of the brain, not the whole brain all at once typically, and it's related to blood flow. And as I say, unfortunately, a thoroughgoing definition is hard. I had a slide in here that I pulled out, which is the New American Heart Association definition of stroke. It is about 15 subheadings, each of which is 2 or 3 sentences apiece. It's very complicated. Generally speaking, there are 3 main ways that blood flow to your brain can be altered. The classic one that most people think of is a so-called ischemic stroke, and it leads to what's called an infarction. This is where blood supply is cut off to the brain. But there are 2 other kinds that get talked about in the stroke literature and popularly. These are the 2 types of hemorrhagic stroke, giving me 3 major types. Hemorrhagic stroke being intercerebral, where the blood spills out of a blood vessel and into the brain tissue itself, and a subarachnoid, where it spills out onto the surface of the brain. And we'll talk about that in a minute. Each of the above may or may not actually cause symptoms, and this is one of the difficulties is that people will go into their doctor, they'll get an MRI because their memory isn't so good, and they will be told that they had a stroke, and they'll say, I never had a stroke, and the doctor will say, yes, you did, it's right on your MRI. A stroke, as we're presenting it and traditionally, is a clinical syndrome. It's a set of symptoms that you get. The same process can occur in your brain without causing symptoms, particularly if it occurs in parts of the brain that you don't have ready access to their function. You can lose large parts of your frontal lobes, for instance, and not even know about it. So you can have relatively large areas of damage in your frontal lobes and not have a clinical stroke. So this is part of the difficulty of talking about stroke. Point is, there are 3 main processes, nevertheless, that get lumped under the things that cause clinical strokes, which is cutting off the blood flow, hemorrhage into the brain, or hemorrhage onto the surface of the brain. So here are those 3 stroke types. The ischemic stroke, here's a brain, and here's a little blood vessel, and there's a clot lodged in the blood vessel, and there's this gray area of dying brain, and that's a classic ischemic stroke. The area that's been damaged, that area is called an area of infarction. The classic intracerebral hemorrhage, right here, there's blood that's spilled into the brain, and we'll talk about what causes that. And then the infamous subarachnoid hemorrhage, where the bleeding occurs in a vessel that's sitting on the surface of the brain for various reasons, and it spills blood onto the surface of the brain. Just very quickly, in this country, about 87% of strokes are ischemic, 10% are the intracerebral, and about 3% are subarachnoid. What is not a stroke? The first thing that I need to point out in a community talk is that a heart attack is not a stroke. People confuse these 2 things very often. I'm not entirely sure why, but people will often refer to a heart attack as a stroke and vice versa. Maybe you don't do it in the room, but I just need to make it clear. A heart attack is ischemia of the heart, and a stroke is ischemia of the brain, to a first approximation. One involves the heart, one involves the brain. Passing out is not a stroke. So people will be told that they had a stroke because they lost consciousness because their blood pressure was low. Our original definition of stroke was a specific cutting off to a certain part of the brain, blood flow to a certain part of the brain. Passing out is you don't get blood flow to your whole brain. That's why you lose consciousness. There are many common stroke mimics that are not stroke. Amongst these is psychiatric issues. So people will come in that are under immense stress, and they'll have events that look like stroke. They're weak on one side, they can't move, they can't talk, and it's what's called a conversion reaction. It's psychiatric, it's not from their brain at all, it's from their mind, and we actually see this in their mind. Cerebral infections, abscesses, drug toxicity, an epidural hematoma in this instance is bleeding even further out on the surface of the brain. What was the actress that had an epidural? She was skiing, hit a tree. Low blood sugar can actually look exactly like a stroke. It can make you weak on one side. It can give you, make you lose the ability to speak. It can look exactly like a stroke. Migraine, you see it all the time. People come in and they look like they have a stroke. I had a patient who had migraines where he couldn't speak and couldn't move his right side. And he kept a card in his pocket for when they rolled him into the ER that said, "It's not a stroke, it's a migraine," because he'd been worked up for strokes so many times. When he couldn't speak, he couldn't tell people. I'm not making that up, that's a true story. Bell's palsy, inflammation in your facial nerve. Anyone see Sewing with Nancy on PBS? Do you know this sewing show? There's a lady that does a sewing show. Half of her face doesn't move, and she had Bell's palsy years ago. So, anyways. After a seizure, people can often be weak on the side opposite of where their seizure came from. So if you seize in the left side of your brain, often afterwards you're weak on the right side. Brain tumors and something called hypertensive encephalopathy. Just having really high blood pressure can make you look like you've had a stroke. Something that I'd like to touch on is the idea of TIA. I want to get the idea of TIA, if anyone has heard of this. I want to remove it from your brain as quickly as I can and replace it with "it's all stroke," and here's why. So an ischemic stroke, the AHA updated definition, the current definition of an ischemic stroke, which is mostly what we're here to talk about, cutting off the blood flow, is an episode of neurological dysfunction caused by focal cerebral, also spinal or retinal infarction. The idea is that there's some degree of irreversible damage, which is an infarction, and it's somewhere in the brain and the associated structures of the brain. A TIA, the old definition was if you have symptoms for less than 24 hours, we're going to call it a TIA. And that has kept people sitting at home. I still see patients saying, "Well, I thought it was just a TIA. I thought it would pass." And what we know is if you take a person who's had a TIA and throw them in the MRI, the vast majority of them have had a stroke, some quite large. It's just that you can land strokes in parts of the brain that you don't immediately notice. And so people will sit at home thinking, "Oh, it's just a TIA." Do not sit at home. The AHA updated definition, because they can't throw it out entirely, they have to give a definition. A TIA is a brief episode of neurological dysfunction caused by focal brain or retinal ischemia, with clinical symptoms typically lasting less than 1 hour, typically 5 to 10 minutes or less, and no evidence of acute infarction. And the way we judge acute infarction is on that MRI, infarction being the irreversible damage to the brain. The problem is that in the era of when we're trying to treat these things with clot-busting drugs, you don't sit around and wait to see if it's going to pass in an hour or 3 or something. Turns out that a TIA is a neurological emergency, and up to 30% of strokes have a preceding brief neurological event that we're calling a TIA. So if you have stroke-like symptoms, you get to the hospital. Here's how we image this. Just a quick thing. This is a CAT scan. This is a CT. And this is the same brain here and here. CAT scan shows both. CAT scan is just a glorified X-ray. And what we're doing is we're taking a slice across your head like this. So if you took a slice right here and one about 5 millimeters above it and took that slice and laid it on the table, it would be like this. This is actually it's backwards so you think. This is the left side, this is the right side. But here's all those little folds on the surface of the brain. And the outside's a little brighter white, that's the nerve cells themselves, and then the white matter is deep to that, that's all the connections between the nerve cells. And that's about a 5 millimeter slice with a CAT scan, and it looks fine, you can't see anything wrong on it. At the exact same time they did an MRI, and this whole bright area is the area of acute stroke. If you do a CAT scan within about 6 hours of a stroke, you don't see it on the CAT scan. If you go to the emergency room and you think you had a stroke and they said, "But the CAT scan looked fine," that's not a thing. A CAT scan acutely will not show a stroke. It's not for showing strokes, it's for showing bleeding. The MRI here very clearly shows an area of stroke, and that's what we go on. This is a special sequence called diffusion-weighted imaging, but it's super sensitive to areas that have lost their blood flow. Down here later on, the next day you may see, here's this little wedgy shape of injury. By the next day, the area that's been damaged starts to swell up, and then you see it on CAT scan. But MRI, this diffusion-weighted imaging, is how we judge areas of infarction versus no evidence of infarction. That's code for we're looking at it on an MRI. Here's the 3 types of stroke. A parenchymal hemorrhage. The causes are high blood pressure. Tumors can bleed, and trauma can make you bleed into your head. Here's an actual pathology slice of an area of hemorrhage into the brain. This is when a blood vessel breaks open and bleeds into the brain tissue itself. Obviously, this was lethal because it's a pathology section. Here's what it looks like on a CAT scan. It's bright white in the brain. That's why we do CAT scans initially in the ER most of the time. And all that pressure on the brain causes people to become sleepy. They get weak on the side opposite. They start throwing up because of increased pressure, and it causes a headache. That's the usual presentation of a brain bleed. The management of that is still very controversial. We're not going to talk about it, but that's one of the mimics of an ischemic stroke. If anyone has questions, just stop me. This is very informative today. So, number 2, a subarachnoid hemorrhage. This is people who have a cerebral aneurysm that pops. So what's an aneurysm? You have these blood vessels on the surface of the brain. You get these little outpouchings on them. It's a little bleb sticking off the side, and they're weak, and all of a sudden they break open. And they aren't in the brain, they're on the surface of the brain. And when the blood pours out, it pours all over the surface of the brain. And here you can see blood now in the little folds on the surface of the brain. That's what a subarachnoid hemorrhage looks like. And it's usually from a ruptured aneurysm, although if you smack your head hard enough with trauma, you can get subarachnoid bleeding as well. And the symptom is classically the worst headache of your life. That blood is incredibly irritating. And it's just devastating pain. Often people become sleepy and start throwing up. Their neck becomes very stiff. They basically get meningitis from it. It's not a bacterial meningitis. It's what's called a chemical meningitis. It's very, very irritating. And they become very sensitive to light, just like anyone else who has irritation of the coverings of the brain. You get very sensitive to light. But here's what we're here to talk about today: ischemic strokes. Again, 87% of the strokes are ischemic. And there are 2 types now. Let's dig down a little bit. 2 types of ischemic strokes. There are so-called thrombotic strokes. And a thrombotic stroke is where a clot locally forms in a vessel and clogs it off. If you have a heart attack, that's a thrombotic event in one of your coronary arteries. This is a thrombotic event in one of your brain arteries. It's either in the large vessels. People know that your carotids get crunchy and hard, and if they get really crunchy, they can close off down here and stop blood flow from going up. That's one of the ways that a bad carotid can cause problems for you. You can also have what's called blood vessel dissection. There was a snowboarder in Utah that died a few years ago. What do you remember her name? She died on the half pipe. She went up and came down and smacked her head. And she actually, as she did that, she wrenched one of the vessels in her neck. It tore and it caused a stroke. She was an Olympic hopeful before the Sochi Olympics. That was from what's called a dissection. It's called a dissection because you tear the wall of the vessel inside and blood dissects its way up in and closes off the blood vessel. Small vessel thrombotic events are little tiny strokes that happen deep in the brain from just wear and tear on the blood vessels from untreated hypertension and aging. And then the other type of stroke, which is very, very important for management, are what are called embolic strokes. There's ones that come from the heart, so-called cardioembolic strokes. The big treatable cause of this is atrial fibrillation. If you have atrial fibrillation, we'll talk about whether you should be treated or not. Also, bad heart valves can do this, and congestive heart failure. Or the other type of embolic stroke. An embolus is a clot that travels from one place to another. So it starts one place and moves somewhere else. And embolic stroke can also be caused by artery-to-artery embolism. Typically, when you have a hardening of a plaque hardened plaque in your neck, it ruptures and throws little clots up into your brain. That's another common cause of stroke. And that's treatable and fixable. You've got 4 arteries that go to your brain. 2 carotids in the front and 2 little vertebral arteries in back. So you have these 2 that you can feel throbbing in your neck. You have 2 that run up the back of your neck that supply your brain stem. So the carotids come off of the internal carotids go up in the front, They're branches off the common carotid, and they supply most of the brain in front. And then the vertebral arteries that most people don't think of in the back actually supply most of your brainstem and the balance part of your brain. And we'll talk about very quickly what those do. So strokes from your carotid. So I want you to look at these because these are symptoms people don't think of very often. People have a stroke and they say, well, I didn't know I was having a stroke because my arm didn't drift and I wasn't numb and I could talk. And that's fine, but they had abrupt onset of double vision and lost vision in one eye, and that's a stroke too. So carotid disease, if you flip a clot to your eye through the ophthalmic, you get one eye visual loss. You can also, if you have a big stroke on the side of your head, so your carotids come up and supply most of this area here. If you have a stroke over here, you can get numb and weak over here because the left side runs the right side of the body. If it's on the left side of the brain, you also get speech issues because the left side of your brain is where you talk from. And a big stroke on that side can make people very confused. I want to stress that strokes in the vertebral arteries. So here's the vertebral artery coming up from the side view. There's your two vertebral arteries coming up from the bottom view of the brain. This is looking up on the bottom of the brain. And this is your brain stem right here, and it handles things like balance and eye movement. And the cerebellum controls walking. So if you have a stroke in your brain stem, you get vertigo, room spinning, you're suddenly throwing up. You can go deaf in one ear. Double vision, real unsteadiness with walking, even if you aren't specifically weak, you're just really unsteady all of a sudden. One-sided clumsiness, not weak, just clumsy. And then you can also have sensory loss or weakness as well. But it's really these eye issues and balance issues that point to the brainstem. And they can be devastating strokes as well. That's the background of the ischemic strokes. I'm going to talk how we prevent strokes, but let me stop there. Does anyone have any questions about the stuff I just went over? The takeaway being that the important strokes and the most common strokes that we're talking about today are ischemic strokes. There are different ways that the blood supply gets cut off in the brain with various mechanisms of getting little clots in there, and the symptoms are the ones that I just presented with special emphasis on double vision and unsteadiness because we miss those often. How do you prevent strokes? I expect a lot of people are here wanting to know about this. How do you prevent a stroke? Well, there's two kinds of prevention. There's prevention before a bad thing happens, and then there's prevention after a bad thing happens to keep it from happening again. That's so-called primary prevention versus secondary prevention. Primary prevention of stroke really goes like this. The first thing, and I'll show you a slide to modify risk factors for stroke, and you already know a lot of these. Is it a really good idea to smoke? No, it's a stroke and heart attack risk factor. And we're going to go over that stuff. It's those kind of things. High cholesterol, diabetes management, that sort of stuff. People wonder about medications to prevent stroke, and that's actually a whole talk in and of itself, because people go to their doctor, they're feeling okay, and they're 68 years old, and their mother died of a stroke at 67. And they really don't want to have one of those. And the doctor looks them over and says, everything looks fine. You know, your blood pressure's okay, your cholesterol's fine. And they say, but doc, what can you put me on to prevent a stroke? And there's actually good guidance on this. It's very complicated to go through, but bear with me, because I'm not going to go through it. This is something to talk with your primary care provider about. But people ask, is aspirin going to prevent a stroke in me? And the answer is maybe. And the answer comes from, there's actually a calculator. You can go online, and there's the American Chest Society and the American Heart Association have a cardiovascular risk calculator. And it takes into account your age, and your gender, your ethnicity, and your blood pressure, and things like that. And it gives you a 10-year risk score for heart attack and stroke. And if you're at or above 10%, then you should start a baby aspirin a day. And that's something to talk about with your primary, but it's just playing the numbers game. They looked epidemiologically who needs to be on aspirin, and the little calculator will tell you statistically whether you should be or not. Atrial fibrillation, an abnormal heart rhythm that can lead to stroke. Turns out that all ages get atrial fibrillation for various reasons, and I've seen 35-year-olds with intermittent atrial fibrillation, and the numbers game says they should not be on blood thinners because the risk of bleeding on blood thinners, full blood thinners, these are drugs like Coumadin or one of the newer medicines like Xarelto or Eliquis, they carry a risk of bleeding. It's the stuff of late night hit. If you've been harmed by Xarelto, call the law offices, that kind of thing. And yes, indeed, people are harmed by these drugs, and that's known, but it helps more people than it harms if you do it right. What's doing it right? You go online to a different calculator called the CHADS-2 VASC score, and it tells you your risk of having a stroke from your atrial fibrillation, taking into account your gender and your age and your blood pressure and your history of heart failure and diabetes and all those sorts of things. And you can decide whether you would benefit. A score on the CHADS-2 VASC of 2 or greater, you should be on a blood thinner. You should be on Coumadin or a relative. And that's something that's easy to calculate with your primary. Aspirin is not sufficient to prevent stroke in atrial fibrillation. This is one of the few settled issues in neurology. Over and over and over, the benefit of blood thinners outweighs the risks for the vast majority of people. I will digress and go to the side just a little bit here. I see a lot of people who have a fall or two and get taken off of their blood thinners by their primary care providers because they don't want them to bleed if they hit their head. The epidemiology of that is pretty clear. You got to do a lot of falling for the benefit of being on blood thinners to be outweighed by the risk of bleeding in your head. The studies suggest anywhere from several hundred falls to an infinite number of falls, that there is no number of falls where the benefit is washed out. Certainly this is a discussion to have with your primary, but 1 or 2 falls, you don't want to do it, but it doesn't rule you out from being on blood thinners, and you're better off being on blood thinners if you have atrial fibrillation, if your CHADS-2 VASC score suggests it. Statins. Everyone's heard about statin, Lipitor, and those kind of things. Should they just put statins in the water? Everyone's on them. Statins have risks. We're learning more about the risks as a neurologist. I'm especially interested in the relationship between statins and cognitive decline. Go no further into that except to say that you can calculate whether you should be on a statin. You should be on a statin as primary prevention if you have a greater than 10% risk plus one of the other predefined cardiovascular risk categories, and you can calculate that one with your primary. One thing that is clear, and if you take one thing away from this entire talk today, it's that the number 1, 2, and 3 thing to prevent stroke to do is control hypertension, and control your hypertension, and control your hypertension. Epidemiologically, it's the most important thing you can do, and hypertension isn't 180 over 130. It's greater than 130 over 80. 130 over 80 is the new guideline. And you should be treating it if you're above 130 over 80. Well, there's again, these are all epidemiologically determined, so there's tables for it. Actually, they recommend if you're sitting around 130 over 80, you give it 6 months of lifestyle interventions and so forth. This is what primary care really, we talk about investing in primary care and why it's important. This is why it's important. This kind of thing is why it's important. So you need a primary care doc that's hep to this stuff. It's very easy to find online, and you can ask these questions. Secondary prevention of stroke is modifying risk factors. But the other 2 things, and also being on blood thinners if you are diagnosed with atrial fibrillation. The only other thing to talk about really quickly with secondary stroke prevention. So you've had a stroke, you don't want to have another. You continue to modify your risk factors, and the other thing is if you have carotid stenosis, you can get your carotids cleared out surgically, and that's the main additional thing to add. What are these risk factors then? High blood pressure, high cholesterol, diabetes, tobacco use, excessive alcohol use, physical inactivity, obesity, heart disease, and atrial fibrillation. I don't know that any of those is really surprising. It's a heart attack and stroke risk factor. Things that you can't control: your age, your gender, your race, your family history, or whether you previously had a heart attack or stroke, although those also can be predictive of having a stroke. How do we treat strokes? For years, we just put patients to bed. You have an acute stroke. You come in, this is back when giants walked the earth and a medical intern could admit 30 patients in a night. because all they do is say hi, put them in a bed, and go to the next patient. Literally, there was nothing that they could do for these things. It was only later that they determined about blood pressure and antiplatelets and all that stuff. For years, the standard of care was heparin. Put people on heparin. You have a clot, put you on heparin. Won't that help? No, it doesn't. It actually kills people, but it made a lot of sense. But it doesn't work. And this is one of my standard things, is that if something makes intuitive sense to do in neurology, odds are good that doing the opposite is actually what we're going. And there's no data for it. Doing the opposite is what's going to actually make sense. And we see this over and over again. You got a clot in your carotid, put them on heparin. No, because that makes their brain bleed and doesn't do anything for the clot in the carotid, because that clot's actually not made out of, it's not red clot. It doesn't look like blood pudding as much as the part of it that really matters is what's called white clot, made out of platelets. So arterial clots don't look, they aren't red, they actually are more white or pink because they're made out of platelets, and that's why you take aspirin for arterial clot. Venous clot, you get a clot in your leg after surgery, that's red, it looks like a piece of blood pudding. Arterial clots, the clots that they pull out of your coronary arteries, have a core that is made out of platelets, and it's so-called white clot. And aspirin looks for that. Intuitively, we didn't know that intuitively. But they found specific activators of the so-called fibrinolytic pathway that actually break down clots rather than preventing their propagation like heparin does. They break down clots, and unfortunately they cause hemorrhage when they were used in stroke trials. But they found this thing called tissue plasminogen activator. It's one of the fibrinolytic clot-busting drugs. And it was tried, and it didn't work very well, because people would come in with a stroke and they just give it, and the brain becomes very soft after a stroke. It's not heart. Heart is tough. Heart's muscle. And so you can put clot busters in the body in the setting of a heart attack, and the heart doesn't explode. Unfortunately, that's not true with brain. When you have a stroke, you've got a time when the brain still has its structural integrity, but after a while, the brain becomes very mushy. And if you give blood thinners to a person too late after a stroke has started, you tend to have hemorrhage. And that's the problem, is that people bled a lot.
It's mushy because of apoptosis?
Well, it's mushy because the breakdown of the blood-brain barrier, and then remember, there's really not great connective tissue in the brain. You've got glial cells, you have astrocytes, and oligos holding all this stuff together. And it's not, a heart is very fibrous. You can take that puppy out and set it on a table and come back and try to pull it apart later, and it's fine. But a brain has the consistency just at baseline of cold oatmeal. And you can take your finger and jam it all the way into a brain with not very much resistance. They're very soft. And that system, once you make it ischemic, it loses all of its structural integrity and it just falls apart and bleeds. In fact, at a microscopic level, it said that every single stroke bleeds to some degree. Macroscopically or microscopically, every stroke will eventually bleed because of that propensity. But in 1995, it's been a long time, they did a study where they said, we're just going to treat people early. First 3 hours, we're going to give TPA. And they did it. And people bled, but not that much. There was a 10-fold increase in brain hemorrhage given TPA at up to 3 hours after symptom onset. That took it from about a 0.6 to a 6% bleeding risk, but something very interesting happened. Even despite that, it did more good than it did harm. And I'll show you some numbers quickly before we hand it over to Heather. Just avoid the tears here. All takers, 30% more likely to have a good outcome, and I'll show you a slide that demonstrates that if you give TPA. So basically, at the 3-hour point, the number of people that were spared from being in a nursing home met the number of people that were harmed by the drug, and that's why the 3-hour time point was set. I'll show you a slide on that. We found that we can safely give it up to 4.5 hours. That's not a lot of time, but it's what we got, and it does work. Just remember that per stroke you lose about 1.2 billion neurons on average. Per hour, that's 120 million. Per minute, it's 1.9 million neurons. that are dying every minute in a stroke, on average. I mean, strokes are different sizes. This gives you kind of a feel for the magnitude of what you're losing in a stroke and how fast it happens. 32,000 neurons per second. It's a rapid process. We also know that the sooner you give TPA, the better people do and the less likely they are to bleed. So the faster the better. Here's that NINDS data, and I want to show you a few things. I don't want to go over it too long, but this is so what we're looking at is the Bartel index, which is people that have a good outcome, and the modified, here's the modified Rankin. So these are what you're seeing here. Let's talk about, so the classic is people with modified Rankin scores. 0 to 1 are completely functional, and 2 to 3 are pretty good. And you took this number of people that were doing fairly well, and you slid the curve over this way. So from no symptoms, you go from 26, and I'll have to look up here, to 39% had a modified Rankin of 0 to 1. That's not day and night, but it's the first thing that even worked. It's not a perfect treatment, but it's certainly better than nothing, and it does help a lot of people when you look in aggregate. And here's the mortality data, placebo. These are so-called survival curves, and there are fewer people surviving with placebo, showing that even though there is some bleeding induced by this stuff, overall you're less likely to die of your stroke. And here's a graphical way of looking at this. You take 100 people that you give TPA to. You will have this many people, which is 13, who are rendered normal who wouldn't have been normal. That's that 0 to 1. That's the sliding of that part of the curve. The 2 to 3 is these light greens, and when you take that total number there, that's 32 people that are actually helped with 3 people down here who are made worse or die specifically because of this. There are a large number of people that will die otherwise. We look at what's called the number needed to treat. For every 7 patients treated with TPA, 1 will recover, and those are the dark green. So 1 in 7 or 13 out of 100 are spared, are brought back to totally normal by this drug. It's not 100%, but it's certainly way better. And it's not just to say that people that get treated, there's more than just people that are made entirely normal who end up better off than they would have been. So how do you do it? Well, it's very hard to do because you have to give it fast, and you have to give it to just the right people, because if you give it to the wrong people, it can cause bleeding. So what do? First, you get people to come in quickly, doing things like this, community outreach, teach people how to look for stroke. You determine when the stroke started, because you can only do it up to an hour and a half after, or 3 hours after onset. We have a little scale to quantify the deficit. You be sure there's no head bleeding on head CT. Be sure that there's not a reason not to give it. You inform consent to be sure they want to give it, and then you give TPA. I'm going to skip over, these are the tools that we use to determine who should get TPA, but we make sure that they haven't had recent surgery or trauma or bleeding in their stool or things like that would indicate they're bleeding somewhere. And you can quantify how bad their stroke is with what's called the Embolic Stroke scale. And I'm now going to turn it over to Heather. Because when I first got here, we weren't doing it very well. We had no thoroughgoing way to do it. It takes a stroke program to do this correctly. And if you would, throw up some of the metrics there.
Oh, that's very nice.
When I first got here, it was just me. Dr. Knappenberger, how are you going to make this work? How are you going to gather the data to show that we're doing this? And I said, you can't do that. You have to hire somebody. They said, there's no money to hire somebody. But finally, they got it. It's an almost full-time job, eventually a full-time job, to oversee this, plus help of a lot of other people. And that's where Heather has stepped in and is unbelievable at what she does. I would say that unreservedly. And I've heard the same from our partners down in Utah. She's the best they've got in the field. So anyways, please.
Can I ask a question real quick?
Sure.
So, when the blood stops and you start having a stroke,
Yep.
how come somebody can come in and say, oh, I didn't know I had a stroke? How come it doesn't just keep going throughout the brain?
So you close off, so that's the thing, is it's a little clot that lodges in a blood vessel and only stuff downstream is hurt, and upstream from that, the blood continues to flow. So people that have a stroke process but don't know they're having symptoms almost never get treated because no one knows to treat them. Happens all the time.
So that part of the brain just is gone, it's just shut down. And that clot is,
Eventually broken up by the body's own clot busting systems, but unless it gets broken up in a very short time, the brain's gone anyways. It's not uncommon that we do an angiogram looking for clot a day after a stroke happened, and you can't find the clot anymore because the body's own clot busting system has broken it down. The vessel's back open, but the brain's been irretrievably damaged, and over time it just gets reabsorbed and leaves a hollow cavity in the space where brain was.
And one more question.
Yep.
Any progress on forecasting stroke?
Forecasting.
Forecasting meaning a person that has not had a stroke, tests that would indicate that they will have a stroke or they're at risk clot forming.
So clot forming is hard except for outside of the setting of what are called prothrombotic conditions. These are relatively rare. They are caused of young stroke. But in older folks, it's the risk factors that we're talking about. One additional thing we haven't talked about is screening for asymptomatic narrowing of the carotid arteries. That's hotly debated and probably beyond the scope of this, except to say that your carotids need to get really, really narrow before it's beneficial for you to get them cleared out surgically, where the benefit of clearing an asymptomatic carotid out outweighs the risk of having one of your major arteries sliced open and have the stuff stripped out of it. So it's a difficult process. We don't have great biomarkers overall for who's just going to have a stroke other than those risk factors and seeing your primary.
So basically you have to have a clot in order to diagnose it.
To have a stroke? No. I mean, if you are an 80-year-old person with atrial fibrillation who is continuing to smoke as diabetic and 100 pounds overweight,
Okay.
I can look at you and say, you've probably got, and we can calculate what your risk is. I can calculate, it's probably 50% over the course of 10 years, probably higher than that you'll have either a heart attack or stroke.
Gotcha.
So, I like how you open up the slide of torture. This is
You don't
my
have to do that.
feedback.
I just set that up to show all the things that we measure.
This is my feedback table, and so every stroke patient that we have that presents to the emergency department, this is the feedback the entire team gets at the hospital, and it just keeps us on track. I get a lot of feedback on this. A lot of people come find me, but really, I'm here to summarize our stroke program and what we've done at Bowsman Health. And so, first of all, I'm going to cover the stroke program levels. And this is important just so you know the resources that are available to you and where we sit as far as access to stroke care in the acute setting. And then our program development. And so how we've built our program, where we're going, and then our results. So, and then a brief little synopsis on where we're going in the future. So, the levels. So, DMVGL is a certification body. There's also a joint commission, and those are accreditation bodies for hospitals to say how well are you doing care. And they also provide certifications. For stroke, there are 3 different levels, and luckily DMV, GL, and Joint Commission, they also have the same leveling system. And so whether you look at Joint Commissions or DMV, GL, there'll be 3 levels for stroke. The first level is acute stroke ready. And what that means at a hospital is that they can handle and have the capabilities, education, to provide acute stroke care. So if you come into the hospital in the ER and you're having a stroke, they're able to help you, stabilize you, evaluate you, and treat you with Alteplase, which is the TPA medication. that Dr. Knappenberger was talking about, and then endovascular treatment. And endovascular treatment is where they actually take a catheter up into your brain and remove your clot. So they'll be able to identify that.
I've got a quick question.
Yeah.
So the patient comes in, the patient's got symptoms of stroke. You do a CAT scan and that tells you immediately if it's an aneurysm, a bleed in the brain, or if it's a clot type thing?
So you, on a CT, you won't see if it's ischemic. So you won't see if there's a clot. What you'll see is if there's bleeding in the brain, and that's what we look for.
So the CT scan is fine for that? It
Yes.
just doesn't show the...
Yep.
Okay.
And so if you look at stroke care compared to cardiac issues, so when you come in and you're having chest pain, your priority is in EKG, right? We want to look at your heart. And with stroke care, it's your head CT.
Okay.
We want to look at your head.
Thanks.
And so, but acute stroke ready facilities really stabilize you, give you treatment, and then transfer you. Primary stroke centers are where you can actually treat the stroke. I'm getting your dog excited, I'm sorry. It must be my voice. So primary stroke center is where you can actually treat your stroke patient, but then you admit them to your hospital and you're able to do that subacute care for your patient, and then also have rehabilitation center places, services in place. And then we have our comprehensive stroke center, which are the top dogs. And these guys have entire floors for stroke patients. They do endovascular treatments, they do neurosurgical intervention. These are the facilities that we look to for advice. And so where do we lie at Bozeman Health? We currently received our acute stroke ready certification last year. And for our future, we're headed towards primary stroke center. How does this look for Montana? Well, it's kind of eye-opening. I'm a Montana girl, so I really am passionate about providing as many services as possible in Montana, but there's also limitations. So, of course, Bozeman I put as a big red star, because we're awesome. But then you have Billings. Billings has 2 facilities that are primary stroke certified. You have Great Falls that is also primary, and you have Missoula, which is primary as well. Notice there is no comprehensive stroke facility in Montana. So we have to transfer outside of Montana to do endovascular services. But I also want you to note the catchment area. So Bozeman, it's really important that we get to that primary stroke level because of our catchment area. We have so many towns close to us that need help. Helena, Butte, Dillon, Livingston, these guys all transfer and need help from us. And so we also hit part of the park. So lots of patients, lots of catchment area. So as I started up in my job, I've been 2 years, is that right, Dr. Neville? 2 years, I think. So I'm a numbers person. I'm married to a physicist. We like numbers. So it's like, we need to collect numbers. We need to see how our care is doing, and then we can identify the areas of improvement. That takes time. It takes quarters of data information. And so in the meantime, we started working with our partners. And so we needed to solidify our partnership. One with University of Utah. So this is the Comprehensive Stroke Center that we decided to contract with and work with. They're amazing. I love them to death. And so we signed a contract that they would provide 24/7 coverage with telestroke. And what this allowed, when I came on, there was only 2 neurologists. They can't provide 24/7 coverage for acute stroke care. And so we contracted with them saying, hey, how about we use your neurology as well? And so when you present to the emergency department, if they are not in-house, we actually hook up it's a TV, and it has a camera on it, and you'll see a neurologist. And they'll do a consult in that acute stroke setting. We also joined the Montana Health Initiative. This is a group that brings all of the stroke coordinators and physicians together, and it's a state collaboration. And so we're working with the entire state to Montana's pretty unique. and we need to work together. We don't need to reinvent the wheel. And so we're working together to provide better stroke care to the entire state, which is really exciting. It's a great workforce. And then we also work very closely with our transfer agencies. So not only do we need to work with them so they can transfer patients safely to us, so we can take care of stroke patients, but we also need to have that clear communication and close working relationships so we can transfer our patients to University of Utah when needed very quickly.
How do you do that? By helicopter? By plane? What-
Yes, so the University of Utah is too far away, we can't use a helicopter. So what happens is that sometimes it depends where the patient is, but we can take the helicopter to the tarmac, so at the airport, they hop on the fixed wing and then go. That's the plan for Big Sky. Sometimes we take an ambulance and drive it out to the airport and fly out fixed wing. It's very coordinated, it's an early activation, and so we're cutting down on that transfer time. So when we're treating the patient in the emergency department, we're calling for transfer if they need to go, and so that transfer team then arrives as soon as possible. So how good are we? How many patients do we see so we can practice this over and over again? We populated the registry for 2017 at 194 patients. We practiced this a lot. So we had 169 stroke activations in our hospital, and this means that there's a pager that's sent out to everyone that would need to be notified to provide excellent care to your stroke. So these guys arrive. Everyone comes in the minute that they get paged out. EMS can page out this, and so it's very important to call 911 right away. So when you arrive to the hospital, your team's ready there, are able to give you care. How many consults do we do with the University of Utah? 71. They're a great help. We love them to death. Hemorrhagic strokes, we saw 23. TIAs, 50 of them.
Let me clarify there, so
This
that's,
stroke.
yeah, I mean, so you can't judge if it's a TIA at home. We know that TIAs are just variants of ischemia, but at the point that you're going to be giving the clot-busting drugs, if their symptoms are pretty much gone, you don't give the drugs. That may not be the right thing to do forever, but that's what we do right now. We have to go on clinical grounds. Because you can have large strokes that don't have a lot of symptoms, there are probably TIAs that we will give clot-busting drugs to in the future when we have better ways of assessing brain quickly. But for now, if you're better at the time we would give drug, we hold it. That's where we're at.
So ischemic strokes, we saw 104, and it's important to note that down below, the next line is acute ischemic strokes. And this is categorized if that patient arrived within 4.5 hours to our emergency department. And why we have that number is that's how far we can treat them with alteplase. So it's sad, right? So, I mean, we didn't even hit 50% that arrived within a treatable window for us. This is why people should not take naps if they start having stroke-like symptoms. They need to come to the ER. But I'm happy to announce that we treated 19 people here at our facility with alteplase. National average for treating with alteplase is 3.4%. We're sitting at 18.3%. That's great. You're at a facility that believes in the medication that improves 1 out of 7 people that get it will have improvement in their symptoms. It's important to give. And then we've had 9 transfers to University of Utah. So you can clearly see that our facility needs to go towards primary. We're not transferring our patients out. We only had 9. And those 9 were large vessel occlusions. And what happens with large vessel occlusions is we want to get them to endovascular treatment. We want to see if they can thread that catheter up and pull out the big clot.
I'll talk about that in just a second after we.
So this is our data. And this is how good are we at picking up on strokes? When I first started, so blue indicates we correctly triaged, green indicates that we over triaged our patient, and then the red is under triage. We focus on under triage because those are the patients that could have a bad outcome if we don't activate our stroke team. And so when I first started, we were at 15%, and I was like, we can't have that. So we came up with a new triage tool. We were like, we need to detect these strokes. And I will cover it in the next slide. it's a very sensitive tool. And so we get an increase in over triage, which we're okay with, right? No one's getting burnt out. But we also were able to decrease that under triage. These last couple quarters, I was like, what's going on? We're coming back up. Why are we at 7.5 and 6.7? And what I found is that we weren't activating for hemorrhagic strokes. And so they come in with presenting with different symptoms. And so it was physician education. Activate your team for hemorrhagic strokes. You'll expedite the diagnosis of your hemorrhagic stroke as well. Exciting. So this is the tool that we currently use at our facility. There's magnets at the back table that you can take home. And these are signs of stroke. If you don't get anything else from this lecture today, take home this. So these are your signs of a stroke that you need to come to the emergency department. This is sudden onset of balance or coordination issues. This can be described as vertigo. You can watch someone and they'll start tipping to one side, they can't walk straight. These are signs of a posterior strokes. They lose vision in one eye. They report that they start seeing double vision, and these are sudden onsets of these. These are two other symptoms that you should come emergently to the emergency department. Then you have your typical FAST, which is your face, so have them smile, any drooping noted, that is a positive. If you have them hold out their arm and they have an arm drift, that can be a positive. And then have them say a sentence, so you can't teach an old dog new tricks. Notice if they're slurring their speech, if they're mixing up their words. And then T is time to call 911. So EMS activation will get our team to the hospital before you arrive. And then last known well. Always note the last time known well so we can treat you with Alteplase. We also treat TIAs. This is a process developed by our stroke team, and it does a calculator. We love calculators. And so this is your risk of having a stroke. So Dr. Knappenberger was talking about 30% of patients had TIAs before they had a stroke. And so these patients, these TIAs, we were saying 30% will go ahead and have a stroke, and half of those will have a stroke in 2 days. So it's a risk factor of how quickly you're going to have that stroke and whether we admit you or whether you're able to do a follow-up within 2 days with your provider. And this is all based off of this algorithm, whether we let you go home or not. HA puts out guidelines for acute stroke care and how quickly can we provide. This is your hospital. And how quickly we provide care. So red is HA. This is national standard guidelines of how fast you should provide care. Yellow is your 2016 and green is your 2017. Just want you to note that we are below national standard and that's where we should be. We want to,
Shorter is better.
yeah, shorter is better. That's what we like. And we also like how every step of the way we're getting better and better. This is my harassment on everyone. And awareness of how quickly they have to provide care. They get gold stars. They like gold stars. And so you can see just from evaluation from the doctor all the way till we contact the neurologist, you get your lab results, and then TPA administration. And then we want to get our patients into ICU as quickly as possible. So this is a breakdown of how quickly, bottom line is how quickly are you going to get this medication here. And national standard is 60 minutes, and look at us step down on our times and get quicker and quicker. Our last quarter, we treated 7 patients with Alteplase, and we had a median of 51 minutes. That's great. That's great.
1.2 million neurons a minute. So that's a difference. And it's hard to do.
Yep.
It's all because of her. It really
I
is.
think so. Okay, so plan of care when you're admitted. So we're going to admit you, and then you're going to come up with a plan of care. This is all based off of just you as the patient and what's going to work for you. So antithrombic, so we're talking about aspirin versus getting on your Coumadin, if it's an antiplatelet versus anticoagulant or both. Then we're going to do hypertension treatment. It's 130 over 80. The new recommendations are not in there. Shoot. And then we evaluate if you have diabetes. So we're going to check your hemoglobin A1C, see how you're doing with your blood sugars, and start controlling you if you're above what we would like. Physical activity, we're going to find out what you like to do and make sure that you're doing it at least 3 times a week for 10 minutes. And then weight control, we're going to take a lipid panel and see where your LDL and HDLs are sitting and possibly do a statin treatment, more than likely. And then we're going to ask you to stop smoking if you're smoking. And then we're going to do an ultrasound of your carotids to see if we can intervene there. So where is our program going? It's obvious we're going to go towards primary stroke certification. We provide this care, we're super close to it. We already provide almost all of this care to become a primary stroke certified, but it needs outreach, right? And so not only do we need outreach into our public to talk about like how to prevent strokes, we need outreach into our facilities close to us. And so we're going to Ruby Valley, provide education there, try to get them up with Alteplase. Bozeman Health, Big Sky is going to start treating with Alteplase in a few months. So lots of training there. And then we're going to push our ER times to treatment within 45 minutes. I also like to say kudos to this organization, Bozeman Health, because they have just dumped a ton of money into education for this certification. So we get to provide lots of education to our staff, physician and nurse-wise, and ancillary services, just so we're all on the same page and we're the best at providing stroke care.
It's hundreds of hours of education and tens of thousands of dollars of training to do this, and they're in. Okay, and now to finish up, what is the future? What are we going to do from here? As I said, the brain gets fairly mushy fairly quickly after a stroke, limiting the use of IV TPA, but for years cardiologists have been able to go up into your heart and grab the, put a stent past the clot and stent open your arteries, and they can do that. Why can't we do that in the brain? Because it's not the heart. Intra-arterial, so you put clot busters into an artery to try to break up a clot directly, and people bled. There was this thing called a Mercy clot retrieval device. It was in the plot of one of these, which one? Grey's Anatomy, or what's the other one?
You always ask me, I don't watch TV, so I was like, oh,
doesn't matter. It was a plot device, but in the real world it doesn't work. But then we have a new way of looking at a brain, and this is the future, and this I'll just go through quickly. You have an area of dead tissue. There's a clot, there's an area of dead tissue, but at the periphery of that, there's other blood vessels coming in, and the brain has overlapping blood supplies in multiple places. So you have an area of dead tissue, but this is salvageable if you can open up the blood supply. That's the so-called ischemic penumbra. And the goal is, so here's that MRI, here's that diffusion MRI, and this is what we get right now. There's your stroke. But the problem is that when you look at the cerebral blood flow, it's impaired throughout the whole side of the brain, and if they don't get that clot out, that stroke's going to end up to be this big. And so the goal is to see when a person comes to the ER, if they have an MRI that shows this much damage, but when you map the blood flow, which we can't do yet, but we're gonna, you have this much area at risk, that's a person who's going to benefit from getting the clot pulled out. And it turns out, and I'm going to go through this super quick, 2 studies, this is from 15, this just came out a couple of weeks ago, that shows that up to 24 hours out, you can grab those clots and safely retrieve them and improve outcomes. And here's those survival curves. This is up to 24 hours you're improving survival in people. Here's how you do it. You run a stent up through the clot, and you deploy this stent, but you're not trying to stent the artery open. You're trying to get the stent mixed up in the clot, and then you just pull the clot out. It's called a retrievable stent. You go through the groin, you run a catheter up into the brain, there's the clot, you put a stent past it, and you pull it out. Retrievable stents, it's the wave of the future. It really is, it works. The problem is this is, I can't go through this, it's too much. This is the new stroke flow flow sheet from the American Heart Association, just came out, and And up to now, so here's the TPA. I need to blow this up. I just cut and pasted it from their thing that was published. At any time less than 24 hours, you're supposed to still be thinking about doing what's called mechanical thrombectomy. Just in the last little bit here, they are now pushing the window out from 4.5 hours to up to 24 hours. And that just happened in the last few weeks. How are we going to get people to Utah, because that's the nearest place that does that, in a timely fashion? How are we going to screen these patients? How are we going to treat them and transfer them? Are we ever going to have people close to home to do this mechanical clot retrieval? These are the big questions that are around right now. Bozeman can't support a dedicated clot retrieval person. We just don't have the volume. You won't keep that person busy enough. How are we going to approach this in the state of Montana to get somebody, maybe Central, maybe in Great Falls, to do this, who's certified? You got to be certified. You got a lot of cowboys that think they can do it, they can't. That's actually a real issue. How are we going to develop pathways to allow advanced stroke care for the population that we serve? We're still working on it. We're working on it every day. She's doing more than me, because that's her job all day, half the day, every day. And Deaconess is all in, and they have been really supportive. It's been wonderful to work with them, and we're looking forward to continuing to improve. That's it. Thanks. A couple minutes over, but we still have time if anyone wants to ask questions. Sir?
Yeah, I was told I have over average potassium in my bloodstream. Of course, that's according to the averages of mainline medicine. But is potassium a indication of stroke? And what would your blood work show about potential for stroke?
So the blood work that shows a potential for stroke is the usual stuff that you're looking at for cholesterol, signs of diabetes, things like that. Potassium really doesn't have a role in this right now. There are markers, there are other things that have been looked at that is beyond the scope of this, trying to figure out so-called vascular risk factors. The risk of heart attack and the risk of stroke, they tend to be the same thing because you only have one set of plumbing, and the arteries in your heart and the arteries in your brain are very closely aligned with one another. And so these are all what are called general vascular risk factors. And we don't have, and the need for biomarkers, good ways to say that person's going to have a stroke and that one isn't, so that person needs to be on a med and that one doesn't. We don't have those yet. It's all of those risk factors that we're talking about up here. So it's cholesterol, hemoglobin A1C, which is a tracking of kind of a rolling average of your blood sugar, that sort of stuff. Ladies. Other questions? Oh, yes.
Is everyone who comes with an acute stroke to the ED eventually referred back to you or Dr. Popwell? Or do they just follow up with primary physicians?
So at this point, we don't have the bandwidth to see everyone. But it turns out that in the same way that everyone that comes in with heart issues and other pathways are winding and are always straight through cardiology, often we can, so if a person comes in who has a stroke and they're found to be an atrial fibrillation, there's really not a lot that we interface with there other than they need to be on Coumadin and following Coumadin in clinic, or probably better, they need to be on Eliquis, which may be a little safer. So not always, and we'd love to see them, but we only have, we say 3 of us, but now Dr. Popwell is actually not seeing new patients, so we're back down to 2 for new patients. Yes?
And then along that same note, are all patients that come in for a stroke go through you guys?
So acute stroke patients, either us or the University of Utah, if we're not on, get called. So there's always, for the acute ones, there's always somebody with that American Board of Psychiatry and Neurology, that's who boards us, approval somewhere.
Because I think, like, because we're with the therapy, there's been a couple patients that have come in through, and you guys always ordered therapy on all the patients for the most part. There's been some that have come through that I don't think went through. I think that was your favorite practice, but can you do
So these are issues that we are looking at. So once they roll in, how to standardize care within the hospital and at the time of discharge is one of the things that we're working on right now.
PTOT speech boom done for a stroke, that's what everyone needs. And you can wave them off, oh, that person's talking fine because they had they have diplopia as their only symptom, then you're done. But it's a part of, if you standardize care, you do the same thing every time, then you don't miss stuff.